Hi, I'm Tara Mastracci, and I'm talking to you today at the PVI, Paris Vascular Insights 2023.
Hello, my name is Jorinde van Laanen, and I'm discussing a very interesting subject as far as I'm concerned with Tara today.
Pelvic venous reflux seems like a very complicated problem to me. So tell me, how do you do the workup? What's your first line of workup?
Yeah, I think, well, it's a very good question. I think even only the diagnosis, like pelvic venous reflux, is, well, basically stating the problem, because we have to find out what patients actually have pelvic venous reflux, and more important, what patients are suffering from it. Mm-hmm. Because it all starts with a chronic pelvic pain. That's what patients present with. But, well, that can be caused by numerous things. So patients often visit the gynecologist, the gastroenterologist, the urologist, maybe even a neurologist. And, well, it's often, it concerns basically, well, young, mostly women. So sometimes they visited numerous doctors, everything is checked, and, well, what's left in the end is maybe it's pelvic congestion is said then, and then patients are referred to the vascular department. And then I think the difficulty is not over yet, because then we have to find out whether the complaints are actually caused by refluxing veins. A lot of people have refluxing veins. Mm-hmm. I think in about 10% of people don't have valves, for example, in their ovarian veins, or as grown-up women, 40% have reflux in the ovarian vein. Mm. So the fact that you find that on duplex ultrasound or MR doesn't necessarily mean that it's a pathology, that it's causing the pain they have. So we have to find a way to make a correlation between patient complaints, the findings, and also, I think, discuss a lot with patients what's affecting their life, how much is it bothering them. Because I think we come from an era that a chronic pelvic pain was explained a lot by psychosocial problems. You know what I mean?
Yes.
And I think we're turning now to the opposite, that having chronic pelvic pain leads to psychosocial problems, but it's not necessarily the psychosocial problems that's the main problem. So we are back to the physical complaints, and then try to find out what actually the problem is. Yeah. And then we're still not there, because then we have a difference between reflux in veins and central venous compression causing reflux, which is also a challenge.
Fascinating. So what is typically your first anatomic target when you do kind of decide that someone has the diagnosis?
If we really have the diagnosis of reflux, then it's usually ovarian vein or internal iliac vein. But important there is that we have to make sure that there's no central venous compression. So if somebody has a compressed left renal vein, then sometimes the left ovarian vein reflux is caused actually by the left renal vein compression. And then we can treat the left ovarian vein, but still leave the problem because the compression is still there. Yeah. The same counts for compression of the left common iliac vein. Mm-hmm. If it's there, then you can have pathological reflux in the left internal iliac vein. And if you only treat the internal iliac vein, coil it, then you don't solve the problem because the compression is still there. So rule out compression first, and if we rule out compression and there is reflux, then treat the reflux. And then the basic targets are ovarian vein and internal iliacs.
Incredible. Such complex work. You've boiled it down so well. Thank you so much.
Thank you.